flexion. Now, if it's unilaterally flexed, it's going to be unilateral flexion on the left. That's what's being shown in on 358. Someone tell me, with the unilateral dysfunctions, are they happening on a normal physiologic axis, or is there a bigger problem here than just something like that? Bigger problem. So they've been knocked off their normal physiologic axis. That's why they don't really respond to correcting in one position over another, like the torsional motions do. So the thing that we have to remember with our unilaterally flexed lesions is that there's an inferior shear component on the side of the flexed sacral base. Okay. And that's why when you did your ILA palpation, if you felt that there was unleveling, meaning one was lower than the other, there was most likely the case when you were on the inferior aspect of the ILAs, likely the case that you had a shear going on there. And is this something that just happens on its own, or is it usually directly a result of some kind of forceful trauma? Trauma. And where does the trauma usually occur with a unilateral flexion? At the base of the ILA. The base. So the base gets knocked forward and shears down off its axis. So essentially, the correction for the sacral base has to first be initiated with that side bend correction. I shouldn't say the side bend, the shear correction. I'll say side bend. So that's why when you look at page 358, there's a little bit more to a setup than just providing a little bit of spring or direction at the ILA. You'll see here for the left unilaterally anterior-rotated sacrum, the left sacral flexion lesion. Patient is going to be prone. It's going to give us an advantage to treating them and working on trying to correct the sacral base asymmetry. What we're going to do here is we're going to have to monitor for the correction. So one hand is going to be over the sacral base monitoring. Our operating hand or contacting hand is going to come at the level of the ILA. You're going to make your contact with pisiform, okay, right over the ILA. And in order to start the treatment, you'll actually have to do a little bit of ulnar deviation to help correct for the shear. The other thing that's going to help along here is positioning the lower limb that's closest to you. So let's see. In this direction number 2, the operator's fingers is monitoring the left. But what you want to do with the lower extremity closer to you or on the side of the lesion is you want to abduct at about 15 degrees. And then you want to pre-position it into internal rotation, because the internal rotation will help gap the posterior aspect of the SI joint. And we want to gap that because we want to try to give the sacral base as much ease in coming posteriorly on that side as we can. So what we do is we abduct the leg and we internally rotate, and it gaps open the back portion of the SI joint. It would be the closed pack of the hip, but we're not treating the hip, we're treating the SI joint.
So that's going to help to gap.
It's going to help to gap. It's going to help to gap the SI joint posteriorly. So we want to open up the posterior aspect of the SI joint on the left. From that point on, it's really the culmination, now that we have that pre-position, the contact, like I said, with the pisiform, that little bit of ulnar deviation to help correct for the shear, and then it's going to be a force once you have the sacrum back on its axis, or close to the axis, of a P to A pressure to help knock then the sacral base backward posteriorly. And then the only thing left to do to help with the muscle energy, we're going to utilize the movement of the sacrum that's associated with the inhalation, because when the lumbar spine, when the thoracic spine extends, lumbar spine flexes, and then the sacrum does what? Counter-nutates, and we want it to counter-nutate. So with inhalation, when we ask the person to inhale, we're going to have them inhale. We're going to take advantage of the sacral motion that's occurring now under the corrected position of the sacrum. And after they inhale and they exhale, what we're going to do is we're going to hold it in position so that then the sacral base can't go back anteriorly into nutation like it would, because now the lumbar spine is going into a little bit of extension. Let me walk through it with somebody so that you can see it happen, please.
Sorry, I was just going to say that you're holding it into position on that left eye.
So I've done the ulnar deviation to help correct the share, and now I'm coming down. See how that pops up the sacrum? Okay. That's what we're going to be doing to help correct it. And we're going to utilize inhalation as our help for muscle energy. Okay. It's not going to be like a big windup of muscle tissue and localization like we've been doing. This is a little more subtle. Yes?
I don't know if that's correct. We have something that says that when we are breathing, like in seated position, the sacral moves differently when we are in flow. Is that right or no?
You know, it's going to go opposite the lumbar spine, which in the lumbar spine is going to go. That would be my understanding. I can check with Professor Ingenito to see if she knows something different.
I'm not sure. I can't remember. My copy says something about that.
I'll give him a call. For the purpose of this exam, if I were to ask you a question, it'll be based on what the material is. Yeah. But remember too, Dr. Makovsky also taught cardiopulmonary. So I definitely want to ask Professor Ingenito too, because there might be an element with cardiopulmonary that I'm not catching here.
Because I think it was in one of the classes, the Tai Chi learning something over here, and the move.
So that was in massage class your first year.
No, they came for cardiopulmonary.
Oh, cardiopulmonary?
Yeah, not that.
I haven't sat through cardiopulmonary, but I'll double check. I'd like to get you at least an answer to your question. So for this demonstration, though, we're going to be utilizing inhalation, and we're going to be localizing like that. Jill, would you come up? Would you mind? Lie prone, leave off the edge, edit that in closer to me. A little more down. Good. All right, you can go over a little more to your right. That's perfect. Thanks. Comfortable? Okay. So first thing we want to do to help with the position is abduct the leg about 15 degrees. Okay? Now with the internal rotation, what we're doing is we're making sure that there's some gapping going on. So we're going to palpate at the SI joint and feel for that gapping. Just to help pre-position things. Now what I need to do is I need to make contact obviously on the ILA. And it's going to be a pisiform contact. So you're not going to be really intrusive to your patient. Okay? So in order to find that, I'll go to PSIS. I'll come down the midline. Get to which bony landmark on the sacral hiatus. Okay. Now I know that that's the midpoint of the S5 segment. Because a lot of you were asking us, what is the ILA? It's essentially the transverse process of S5. It's just that they're all fused, so you're not really making that differential. And remember, for the ILAs, they kind of taper down and get a little more narrow as you go towards the coccyx. I said ILAs. The sacrum itself narrows as it goes towards the coccyx. So you're not going to go as lateral as you would to assess for the basis. All right? So PSIS, sacral hiatus, coming now out, and I've got the ILAs. So essentially the transverse processes of S5. All right? Now to make it easier for yourself, I think it's good practice to get in the idea of pre-positioning yourself, almost like we did with the Texas twist, so that when you finally ulnarly deviate, your fingers are now pointing to the head of the patient. And in this correction, you're going to face the patient's head. So what I did was I came in on a 45 degrees with my pisiform contact, got on the ILA, so fingers are pointing off on a 45 to the left. I now implement with ulnar deviation to help correct the inferior migration of the sacrum. Okay? I'm also palpating over the sacral base, because now what I want to do is when I give a small P to A force, I want to at least start to feel the sacral base coming back into counternutation or extension. Okay? And I've got that here. And the only thing left for me to do is to get my patient helping me by doing inhalation. So I'll say, Jill, I'd like for you to take a nice deep breath in. Deep, 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 until you feel the motion happening. I feel the motion, I feel the motion, I feel the motion. Hold it. 2, 3, 4, 5. I'm doing a forceful P to A at the sacral ILA on the left. Now relax, and this is the important part. When she relaxes, I can't let this happen. I need to stay in position, because every time she goes down, lumbar spine goes down into extension, she's helping me to do the extension at the sacrum, the counternutation, the nutation, sorry. Let me say that again one more time, because if I keep saying extension and flexion, it's going to get confusing. Take your inhalation in. The lumbar spine is starting to flex, and I'm getting counternutation at the sacrum. Okay. Hold, 4, 5, relax. And instead of just letting the pressure off, I'm going to hold her in the position of counternutation. And again, breathe in. Deeper, 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 deeper. Good, good, good. You want to be able to feel that motion underneath your hand. And relax. And that's it. Then you remove your contact and you reassess. You can assess first for the leveling of the ILAs, because you're already prone. And then you can also have them go into that prone prop-up position, and then to sit back on your heels to see if now the sacrum is starting to move in normal mechanics. Could you also have them just stand and see with anterior and posterior tilting if the mechanics are working well? Sure, you can do that as well. But you want to reassess after the treatment. Joanne?
How much force do you apply?
Good force. I mean, I'm able to, I dropped the table down a little bit lower so that I could use the weight of my body on it. Remember that it's off its axis, so you're going to need to apply maybe a little bit more force than you would just getting to the feather edge of the barrier and applying that slight bit of force. But you're still going to do that localization, and the big component here is doing that ulnar deviation and then dropping down. Okay? So let's practice that. Remember the first setup, abduct the leg 15 degrees, internally rotate the hip so that you can start gapping the posterior aspect of the SI joint. Matt?
So, you said when the patient inhales, then
I'm providing that force, P to A, at the ILA, tilting back the sacrum while their inhalation is also helping me. When they exhale, I don't allow that motion to be lost. I hold it in position. And then I go through the next cycle of muscle energy. Okay? So I'm going to talk you through these together. Thank you so much. Can you saw how it was different when you took